Hello, everybody. Welcome to another expert talk. You know, we call it a disease, but this challenge is with us 24 hours a day, 7 days a week. And sometimes at 3 o'clock in the morning, you're just wondering, what can I do for myself that Everything ALS has talked about in the last several years? Well, it's in our app, and you can go there, sign up for free, and you will have access to everything that we've ever talked about. And you'll have access to the Pathfinders, which is a group of folks who are on this path with you. And tonight, I'd like to say that we have a special guest, Dr. Bedlack, and we have 2 of his ALS reversals with us tonight, myself and Kathy Cummings.
Wow.
My name is McFinn Levere, and Kathy and I have both been down the road, and we came back. And so I just want to say there is hope for everyone. And with that, I'll turn it over to you, Indu.
Thank you. And I just wanted to add that both McFinn and Kathy are pathfinders. So you can actually talk with them and interact with many other pathfinders in our app. So with that, Dr. Richard Bedlock, we welcome you, and we're so excited to have you here. I think when I met McFinn and when we referred him to you to see if he's really a true reversal, that was my turning point, because I just lost my husband, and we were really at the place of, is there hope? And you really gave me hope to start Everything ALS and kind of bring everybody together. So with that, Dr. Richard Bedlock grew up in a small town in central Connecticut. He went to college at William and Mary in Virginia, then back in Connecticut for an MD, PhD in neuroscience at UConn. Finally, he came to Duke, where he completed his medicine internship, neurology residency, neuromuscular fellowship, and master's in clinical research science. He's recently a Stewart, Hughes, and Wendt distinguished professor of ALS at Duke and director of Duke ALS Clinic. He has won awards for teaching and patient care, including Best Neurology Teacher at Duke, Healthcare Hero, Strength, Hope, and Caring Award, America's Best Doctor, and America's Academy of Neurology Patient Advocate for the Year, and Rossman ALS Patient Advocacy of the Year, and Niels Gupta Prize, and International Forbes Norris Award. Not surprised at all with everything you do. He has received ALS research grants, participated in ALS clinical trials, published more than 150 ALS articles. He's a leader of International ALS Untangled program, which utilizes social networking to investigate alternative and off-label treatment options for patients with ALS, and leaders of ALS reversal program, which attempts to understand why some people with ALS recover from it. And to make this happen more often, he lives in Durham, North Carolina, with his wife, Shelley, and 2 mischievous cats. So with that, Dr. Bedlock, it's our honor to have you here, and the floor is yours.
Thank you for having me back, and do really appreciate it. So thank you, everybody. Some of you may have seen me give similar talks to this in the past. There's always going to be a little bit of overlap, because I know we'll have some new people that haven't seen me speak before. But I promise for everyone, there'll be something new in this talk that you haven't seen before. So what I thought I would do is just give you a brief review of what normal ALS progression looks like. I'll tell you about how I define slow progressing patients, and I'll tell you about a theory that I have for why they may be so slowly progressive. Then we'll talk about ALS reversals. I'll tell you how I've decided to define these cases. I'll tell you about 2 different programs I'm using to try to understand them better and maybe make them happen more often. One is called ST.A.R, Study of ALS Reversals. I'll just summarize a whirlwind of more than 10 years worth of work and tell you what I'm most excited about that I found so far in that program. And then we'll talk a little bit about R.O.A.R, replication of ALS reversals. And again, summarizing a lot of years worth of work, but telling you about my latest trial, which is just finished. And I do have results to tell you about tonight. And that's the ROAR-DIGAP study. I'll tell you about something that I think all outliers, all people who are doing unusually well with ALS have in common, and that's hope. And then finally, I'll tell you about my very latest endeavor to try to understand outliers, people with super slow progression or reversals. And that's using a tool you might have heard of called artificial intelligence. So let's go all the way back to when I saw my first person with ALS back in 1997, believe it or not. I was still a resident at Duke, and I'll never forget that case. And I'll never forget, not only the collection of things in that person's history and their neurological exam that fascinated me, but I'll also never forget the way the attending that I was learning from talked to that patient. It's something that left a scar on me. I never want to hear anyone talk to that way again. But one of the things that he told me was that people with ALS always experience progressive disability and shortened survival. So that's what I believed. And, we've got ways of measuring disability in ALS. The most common one is called the ALS Functional Rating Scale, ALS-FRS. We're using a revised version now, so you'll hear the term ALS-FRS-R. Many of you probably have had this administered. It's 12 questions that we ask you. Each question relates to a specific motor function like riding, feeding, dressing. And each time we'll give you a selection of potential answers ranging from 0, which means you can't do that thing at all, to 4, which means you can do it normally. And if you look at a large population of people living with ALS, this scale declines fairly linearly at about 1 point per month. And then we can also measure survival, and it turns out not to be quite as straightforward as you might think, because you have to decide if you're going to allow someone to have a tracheostomy and still count as being alive. I mean, that sounds strange, but the thing about it is once someone has a tracheostomy, they don't die from ALS. And so most studies use the term tracheostomy-free survival as a measure of survival. And if you look at, again, a large population, the average tracheostomy-free survival is 3 years from symptom onset. But it didn't take long in my career for me to realize there's a lot of variability, no matter how you measure it. So if we look at the ALS-FRS-R, you can see on the left-hand side of this slide, each one of these lines represents the scores of one person living with ALS, followed over time. And you can see that some of the slopes are very flat. Some of the slopes are very steeply declining. The same thing's true of tracheostomy-free survival. I told you about the average, but 20% of people can live 5 years without a tracheostomy. 10% can live 10 years. 5% can live more than 20 years. And there are examples of people living great lives for many decades with this disease, like Stephen Hawking. It took me even longer to realize this. Not only is there variability between people living with ALS, but there's variability in progression in one person living with ALS over time. And the way that we kind of studied this and eventually proved it to the world is we followed people who were in this database called PROACT. PROACT is a place where all the data from previous clinical trials eventually gets stored. So there are literally now thousands of people living with ALS in this database who participated in previous trials. And we focused just on the ones who were on placebos because we didn't want to have any question about whether they got something that might have helped them. We just wanted to see what the natural history of progression was in people in this database. And again, we focused on this measurement, the ALS-FRS-R. And so what you see in the upper right-hand corner of the slide is one person in that database who was followed for 600 days. That's their ALS-FRS-R score on a placebo. You can see that that is not a linear progression. There's periods of time where there's no progression at all. There's periods of time where there's a very steep drop in points on that scale. And there's even periods of time where they seem to recover some lost function, unfortunately, just for a little while. And so we got this idea that it wasn't that uncommon for this to happen. And we decided to analyze the whole database. And so what you see in the lower right-hand corner there, those curves represent the proportion of patients having different amounts of ALS-FRS-R stability or improvement lasting different amounts of time. So let me explain that to you. There's a line that almost appears Duke blue here. This is the percentage of patients in that database whose ALS functional rating scale was perfectly stable for some length of time. So if you're asking how many people have it stable for 60 days, gosh, it's a lot. 70% of people in the database had a stable score for 60 days. If you go all the way out to a year, you can still find that about 15% of people in that database on placebos had a stable ALS-FRSR score for an entire year. And this green line is the number of people who had an improvement of 1 point, an improvement of 2 points, an improvement of 3 points, or an improvement of 4 points. And so if you're looking over a short period of time, like 60 days, about 8% of people on a placebo can have an improvement in their ALS-FRSR score of 4 points. But that becomes very uncommon as you go out further, very uncommon even at 6 months. And so when I published that paper, I was, I guess, not surprised that it was met with a lot of skepticism. And one of the big complaints that I heard was, well, this is not the disease. This is just the scale. There's a problem with the ALS-FRSR score. And so I started to look around, and other people were publishing different ways of measuring the disease. And so this is a completely different group. I was not involved in this group. And they found a similar thing with the ALS-FRSR. These are the percentages of people in their database who had a stable or improved ALS-FRSR score lasting different amounts of time. Again, it's not that uncommon for this to happen over 3 months. It's still reasonably common when you go all the way out to a year. Almost 6% of people have a stable or improved ALS-FRSR score. But they went on and measured strength. So something called the MRC grading, which is a summary of muscle strength in the arms and legs. And you could see that it's very similar. And they measured a clinician's global impression of change. So they asked the doctor taking care of the patient, do you think the patient is the same, better, or worse? And you could see, once again, it's pretty common that doctors think their patients are the same or better over short periods of time. But even when you go out to a year, some doctors thought their patients were stable or better, 23% of the time. The most famous person who ever lived with ALS, Lou Gehrig himself, whom the disease is sometimes named after, he probably experienced a small ALS reversal. And so we figured this out. There was a guy named Dan Joseph, an amazing baseball historian who was publishing the definitive biography on Lou Gehrig. And he reached out to me and he said, I saw something strange that I want your opinion on. So let's take a look at Lou Gehrig's career batting average. Batting average is hits, number of hits divided by at-bats, but also look at his slugging percentage, the total number of bases decided by at-bats. So you get rewarded for hitting doubles, triples, and home runs when you look at slugging percentage. When you look at his career numbers, he's one of the best of all time. A 340 career batting average, a 632 slugging percentage. Now let's take a look at his last full year, when we know that he already had significant symptoms from ALS. If you look at most of the year, April 18th to August 6th, his batting average and his slugging percentage were way down below his averages. But all of a sudden, for most of the month of August, he just exploded. Like he was doing better than he had ever done as far as batting average and slugging percentage. Unfortunately, it didn't last. By the time the playoffs rolled around, he was back down below his averages. But something strange happened to Lou Gehrig in August of his last full season in the majors. And Dan Joseph looked at the pitchers he was facing, and they weren't any better or any worse than the pitchers he faced any other month. They looked at the type of bat he was using, the swing he was using. Nothing really seemed to explain this, except possibly a variation in the natural history of his ALS. So I've been asking myself for years, like, there's something here. There's something in these outliers, these people who are doing unusually well with the disease. If I could just understand what that was, maybe I could make it happen more often. And I got a clue during the pandemic. I had 2 patients I was following that were hardly changing as far as their ALS-FRSR over many years. So you can see that these 2 graphs are 2 patients with their individual ALS-FRSR scores, and they're really almost flat for years. And then they got COVID, and they got put in the hospital, and they got pumped full of antibiotics, and they both got terrible diarrhea. And you can see that their ALS-FRSR scores just plummeted. In fact, one person died within a few months of getting COVID from respiratory failure due to ALS. The other person, who had always walked in to see me for years using just a brace on his ankle, became wheelchair bound and never walked again. So it made me wonder, was it something that happened to their gut microbiome that might have explained why their progression just exploded? And so with some partners in MOF, Martha Olson Fernandez Foundation, and Augie's Quest, we got the resources to look at the stool of people from my clinic, either fast progressing patients or very slow progressing patients. And we defined those outliers as fast progression being more than 1.5 points per month on the ALS-FRSR score, and slow progression being less than 0.5 points per month. And sure enough, the composition of the microbiomes are quite different. So people who are progressing quickly, they have much more complicated microbiomes in their mouths and in their stool. Whereas those with very slow progression, their microbiomes are very simple, and they're high in this one organism called P. vulgaris. So he said, well, that's really interesting. No one's ever described this before, but it could just be an association. I mean, maybe there's some other thing that slow progressors are doing that's really the reason for their slow progression, and it also changed their microbiome. Like maybe their diet was better. So we said, well, let's take stool from these patients and let's put it into our genetic mouse model of ALS. And we put the stool from fast progressing patients into the gut of that animal. It sped the disease right up. We took that P. vulgaris that we isolated from slow progressors, and we put it into that same mouse, slowed it right back down again. So it really looks like this is more than an association. There really is something in the gut microbiome that might be influencing the progression of the disease. So we're not the only ones to be thinking about this. In fact, over in China, there are some case reports of something called fecal transplants, where you actually take the stool of a healthy person and you transplant it into the gut of the person with ALS. Now, in both cases, these were not done primarily to treat the ALS. They were for other reasons. But in both cases, the fecal transplant was associated with a marked slowing in the progression of that person's ALS. So that prompted a trial, a clinical trial. And I have to say, in my opinion, after now several years of studying this, I don't think they did their fecal transplants in this trial correctly. As evidence of that, they didn't actually change the gut microbiome of the people in the trial. So it's not surprising that that fecal transplant trial did not slow the progression of ALS. I mean, obviously, if you think you have to change the gut microbiome to slow it, and what you didn't change the gut microbiome, it's not surprising if it didn't slow it. So I'm happy to say that we have a wonderful group of collaborators at Duke and the University of Minnesota that know a lot more than I do about the gut microbiome. The folks at the University of Minnesota have a product, an encapsulated stool product from a healthy donor who has a very simple gut microbiome like the one that we think we need. They've already put this product into humans with other conditions. And so we didn't need to build a whole new product, which would have taken years. And we actually have a fecal transplant team at Duke that does these for other indications. And so we believe we have a protocol that's quite different than the one that was used by that previous group. And we have the greatest confidence that we will change the gut microbiome with our protocol. Question is, will we also change progression? I hope so. We will be enrolling our first patient in that trial probably in the next 2 to 3 weeks. So probably what most of you came to hear about is the most extreme group of outliers, the ones that I've come to call ALS reversals. Now, it took me a lot longer than a few years to recognize this group of people. So if I started around 2001, it wasn't until 2011 that I first came across somebody that I believe was an ALS reversal. And this was in the midst of an ALS Untangled review on energy healing. You may have heard earlier that I run this program. It's kind of like the X-Files of ALS. I guess that makes me the Fox Mulder of ALS, but people send me all kinds of wild ideas to investigate, and I try to track them all down. I try to always investigate them. In this particular case, someone asked me to look at the website of an energy healer named Dean Kraft. And I remember, there were dozens of testimonials from people with different kinds of diseases, but the one that struck me was a video of a woman named Nell DeBus. And in the video, she described herself as developing gradual, painless limb onset weakness at the age of 43. This rapidly progressed to where she couldn't walk. And within a year, she was actually completely paralyzed and short of breath. She was seen at the University of Virginia. She supposedly had a thorough workup there, was diagnosed with ALS, had progressed to where she was, in her words, picking out the outfit that she wanted to be buried in. And then she went to see Dean Kraft and supposedly rapidly improved over the next 2 years, all the way back to normal, and was still normal at the time that this was done. So of course I was skeptical. You can't believe everything you read on the internet, but I found her. She's a very nice person. And after reading through those records, I was convinced she really did have ALS and she really did recover. The thing I don't know is why. So I attempted to study Dean Kraft. He did not want to be studied. He said, Richard, for those who believe, no proof is necessary. And for those who don't, no proof will ever be enough. And so couldn't study him, but it did prompt me to ask other members of my ALS Untangled team if they'd ever seen a case like this. And much to my surprise, they had. In fact, cases of ALS reversal had been reported all the way back to the 1960s. It's just that nobody really knew what to do with these. So at the end of most of these cases, the person who wrote it said, we weren't sure, we must have misdiagnosed this person, and we sent them on their way and told them to have a good life. So I said, well, maybe we need to start putting these folks together into a database and trying to understand if there's something that they all have in common. After all, there is a precedent, at least one, in medicine for studying people who are unexpectedly resistant to a disease. So I would point to a group of people called HIV elite controllers. These are people who get infected with the HIV virus. You can measure it in their blood, but they never get sick. They never come down with AIDS. And so for a long time, people just shrugged their shoulders, didn't know what to do with these folks. And then somebody decided to put them all in the same database and study them. And it turns out that a lot of them have the same genetic alteration. It's in a gene called CCR5. The alteration they have is called CCR5 delta 32. This caused scientists to hone in on what that gene did. It turned out it coded for a protein in the surface of all cells that HIV needs to get in to make people sick. Nobody knew this before they studied these elite controllers. And so Pfizer was the first drug company to jump on this discovery. They made a CCR5 blocker called Maraviroc, and it's part of the reason why so many people can do so well with HIV now. So if you're going to study something as a scientist, you have to figure out how to define it. The thing you don't want to do is just say, well, an ALS reversal is somebody who says they had an ALS reversal. That's clearly not going to be rigorous enough. So for me, I've got to have enough information either in a publication or in a person's medical records that I believe the ALS diagnosis is correct. It's got to be the right story, the right exam, the right EMG, and the right testing for mimics. Second, there's got to be progression of that person's weakness to where they're disabled. So it can't be someone who said, I think I had ALS, I couldn't lift my pinky finger, and a couple of days later, I could lift my pinky finger. It's not going to work for me. There's got to be much more robust progression than that. And then finally, there's got to be dramatic and persistent recovery of lost motor function. Now, this is the one where some of my colleagues get upset because they say there's got to be a more rigorous way to define it, like maybe some number of points on the ALS FRSR score. Well, some of these folks never had that score measured. But what I would tell you is if you look at what they're describing, there's no question that something amazing and unexpected happened. Someone, for example, who was ventilator dependent, couldn't breathe without a ventilator, now breathes on their own. Someone who couldn't swallow and had to have a feeding tube for all their hydration and nutrition, who now swallows normally. Someone who couldn't speak and had to use a speech generating device, who now talks normally. Someone who was wheelchair bound and now walks, and in some cases can even run. someone who was completely dependent upon a caregiver for everything, feeding, dressing, bathing, and now they can do all that stuff by themselves. In addition to a definition, you got to have some hypotheses, some theories that you can test. And I got three. The first is maybe these folks who wrote these papers were right. Maybe these were mimickers. Maybe they never had ALS in the first place. The second is maybe some people are just born with something that's going to allow them to beat ALS if they get it, like the HIV elite controllers. And then finally, maybe some of these folks stumbled onto a treatment or a combination of treatments that reversed their case of ALS. So I personally do not believe that any of these ALS reversals that are in my database were mimics. And the reason is this: ALS was first described around 1870. I mean, if there was something with the same history, the same exam, the same EMG, and all the testing for mimics that we currently do, somebody should have discovered it and named it by now. I mean, I really believe that these folks checked all the boxes for what we call ALS. 4% of the ALS reversals I know about had a family history of ALS. That would be really weird. I mean, having a family history of ALS is not that common. So for you to say, well, these people had something completely different that mimicked ALS, they didn't really have ALS, but they had a family history of ALS, that would be an awful coincidence. The other thing is, when you look at how these people recovered, it's not science fiction. There's a process which is called collateral sprouting. And we know about this because of another type of motor neuron disease called polio. This is a motor neuron disease where you get sick with a virus. In some cases, the virus goes out of your GI tract and into your brain and spinal cord and kills motor neurons. And if you survive that, you can actually recover, in some cases, all the way back to normal. So there are examples of people who were paralyzed completely from polio, even in a respirator called an iron lung, who recovered all the way back to normal. How did they recover? Did they make new motor neurons? They did not. They recovered through something called collateral sprouting. You cannot make new motor neurons as an adult. And so what happened in these patients is that the motor neurons that were left over, they sent off branches. So imagine if you were looking at your biceps muscle and it was, affected by polio to where you couldn't bend your elbow at all. Maybe polio wiped out 99% of the motor neurons that used to innervate your biceps muscle, and you only had 1% left. Well, over time, that 1%, each one of them can sprout 100 branches, which can completely reinnervate your biceps muscle and make it strong again. But when you stick a needle in that muscle, when you do an EMG, you can see that something terrible happened to the motor neurons in the past. It is not normal on an EMG. And so for the few ALS reversals that I'm studying that had an EMG after they recovered, this is exactly what we see: evidence of collateral sprouting as a way to recover. So I'll tell you about this ST.A.R program, which stands for Study of ALS Reversals. These are the 4 parts to it. First, I'm trying to find as many of these cases as I can, the ones that meet my definition. And so I'm advertising as part of the reason I do talks like this. Anytime somebody contacts me, the first thing I do is I ask them to help me get their records. And I'm looking for the things that I just told you about. And I can say that as of this week, we now have confirmed a total of 64 ALS reversals. And so for those of you that are following this work closely, you will recognize that that's 3 new ALS reversals just in the past year. That's the most I found in 1 year since the first year that I did this program, when I found most of the cases. And I do believe, from what I saw last week at the Northeast ALS Consortium meeting, I do think we're going to see more ALS reversals in the next few years, lots more. And the reason is because we are figuring out how to manipulate genes. And we know that at least 12%, and maybe more, maybe many more cases of ALS have a genetic component. And as we learn how to turn off genes or rearrange genes, edit genes, I think you're going to see many more ALS reversals. And these are going to be driven by science. So the second part is I'm trying to get all these people into the same database. We're the first ones to do it. This allows us to look at their demographics, their disease characteristics, their comorbidities, the treatments they took, including the alternative therapies. And we can compare all the things that we learned to patients with ALS who are in large databases who are not getting better. We want to get as many biological samples on these folks as we can. So ideally, saliva samples, stool samples, blood samples. It allows us to look at things like genetics, proteomics, metabolomics, the microbiome. And then finally, we want to ask them as many questions as we can, because we want to understand what kind of things they might have been exposed to over the course of their lives. And so if I could summarize the most exciting things I found in the ST.A.R program so far, it's that 2 of the ALS reversals that we've been able to genotype have known ALS-causing genetic mutations. So again, further evidence that these are not mimics. So one had a mutation in a gene called sequestosome 1, and one had a mutation in a gene called FUS. Second, none of the ALS reversals that we genotyped had any genetic evidence for any ALS mimic. And finally, and maybe most exciting of all, when we compare the reversals to ethnicity-matched controls, reversals are much more likely to have a genetic alteration in a gene that controls the level of a protein called IGF-BP7. So specifically, the alteration that they have appears to drastically lower the amount of IGF-BP7. That's very interesting. IGF-BP7 has never before been thought of as being potentially involved in ALS. But among its many functions, it interacts with a growth factor called IGF-1, insulin-like growth factor 1. Specifically, IGF-BP7 blocks the interaction between the growth factor and motor neurons. So with less of the blocker around, there can be a better interaction between the growth factor and motor neurons. In other words, they can be more resistant to whatever it is that's trying to kill them. This also links my finding back to something that was very exciting 20 years ago, and that is the literature on IGF-1 and ALS. So once upon a time, two groups of people showed that if you increase IGF-1 levels in a mutant animal model of ALS, you can drastically slow progression. And somebody showed that if you just look at circulating levels of IGF-1, people who are progressing much more slowly have higher levels. People who are progressing fast have lower levels. And so all this prompted a series of clinical trials. I believe there were 5 different clinical trials where they tried to give IGF-1 to people living with ALS. And for the most part, these failed. And a few years after they were done, somebody wrote a very sobering editorial and said, it's a shame that we kind of turned our back on this finding because none of these trials did it right. The way that they gave IGF-1, it could never have gotten into the brain, and it could never have stayed around long enough to do what it probably needed to do to slow ALS progression. So in other words, those trials were not only negative, they were inconclusive because they didn't hit the target in the right way. So what about IGF-BP7 itself? Well, turns out, you do a literature search, you find it in other neurological diseases. So in patients with multiple sclerosis, they have higher levels of this protein in their brain and spinal fluid compared to people without multiple sclerosis. Same thing's true in Alzheimer's disease. A really interesting mouse model study. They have an Alzheimer's disease mouse model. And so in that model, if you look in the hippocampus, the part of the brain that deals with memory, there are elevated levels of IGF-BP7. What's really interesting is if you inject an antibody into that part of the brain, you can actually normalize this animal's ability to do memory-oriented tasks, like find its way out of a maze. So in other words, lowering IGF-BP7 seemed to correct the Alzheimer's-like disease in this mouse model. So we just published a paper, which was a collaboration across 4 different groups to look for IGF-BP7 as a possible ALS target. We looked within the ALS TDI, ALS Research Collaborative, and sure enough, people with ALS in that database have higher blood protein levels, IGF-BP7 protein levels compared to healthy controls. We looked in the New York Genome Center's brain and spinal cord database, and we looked in iPS-derived ALS motor neurons from Answer ALS. And in both cases, we found higher levels of IGF-BP7 messenger RNA when those samples came from people with ALS than from healthy controls. We reached out to a group called Precision Life. They've got this fascinating idea. They think they've developed a model that can predict ALS. So they think they can look at a young person in their model and determine how likely they are to get ALS. But if that's not interesting enough, what they're doing is they're looking at people who are in large databases who achieved an old age, but never got ALS. People who should have got it according to their prediction algorithm, but never got it. This is called an actively protective analysis. They're looking for things that might protect people. And guess what showed up? An antisense to IGF-BP7 in people who seemed to be resistant to ALS. So this is another observation that came after we published this paper. I mentioned earlier that we had to ethnicity match to find this thing in our ALS reversals. That's because essentially all of our ALS reversals are Caucasian. So if we didn't ethnicity match, we would have had all this noise from the genome of people from other races and ethnicities. But it turned out there's something really important in African Americans and Asians. People who are resistant to ALS, it's very rare for people who are African American or Asian to get ALS. They actually have the same genetic abnormality that we found in the ALS reversals. And it makes me wonder, is that why so few of them get ALS? So this is looking really promising. I will say one thing that gives us a little bit of pause is ALS TDI did not show any correlation between IGF-BP7 protein levels and the rate of progression. But it's a very small study and they were focusing on blood levels, and it's probably brain and spinal fluid levels that matter. So we feel like there's now enough evidence from all this to conduct the first ever trial attempting to knock down IGF-BP7 in people with ALS. And lo and behold, one of my colleagues, Ben Brooks, who's a walking encyclopedia, I don't know if he's listening to us tonight, but Ben, thank you for this suggestion. He actually found an obscure paper that was looking at training in military veterans and whether this supplement used by bodybuilders could improve their ability to train. It's called hydroxy-beta-methylbutyrate, abbreviated HMB. But what was so cool about that paper was they measured a ton of different biomarkers in the blood of these soldiers, and they never really explained why. But IGF-BP7 was one of the biomarkers, and it went down significantly along with HMB supplements. So that's what I'm going to use in my next ROAR trial. And speaking of ROAR, we said it's possible, one theory as to why some people got better is because they might have found some treatment or combination of treatments that made them better. I personally think this is a long shot, but it's not impossible. After all, there are examples of patients discovering the effects of drugs that doctors and researchers had never dreamed of. It's called serendipitous drug discovery. Viagra is the best known example. That was being studied for heart disease. It probably would have been thrown in the dumpster because it didn't work for heart disease, except that male patients in the study at the end said, you know, we'd really like to have some more of this drug. And researchers were like, what? It does what? And they went back to the drawing board and studied it for erectile dysfunction. It became the first-in-class billion-dollar blockbuster drug for males with erectile dysfunction, discovered by accident. And so I created a trial program called ROAR. And this is a series of small trials. Each one is going to test an alternative or off-label treatment that's associated with an ALS reversal. And because most of these products are regarded as safe by the FDA, and because we're looking for such a huge signal, not just a slight slowing in this noisy disease, but a reversal, we can enroll almost anybody in one of these trials. We don't need to be so careful about selecting people who are real early in the course of their disease with a certain amount of function and a certain progression rate. We don't need placebos in these trials. Again, if somebody who's wheelchair bound walks at the end of a 6-month trial, it's not going to be a placebo effect. We don't need a lot of in-person visits, which are difficult for people living with ALS. We can do a lot of these through video. And last but not least, I'm publishing all my protocols online because I know that people living with ALS around the world want to try things. And why not give them a roadmap? If I spent a couple of years working on one of these protocols, why not give them a roadmap so that they could try exactly what we're doing with their own doctor. You get a drink here. So I've already done a few ROAR trials. Lunasin, a supplement from soybeans, theracermin, a water-soluble form of curcumin, both associated with ALS reversals. Unfortunately, neither one of these things worked. They didn't slow, stop, or reverse anyone else's ALS. So I currently tell my patients not to take these products. But I will say these trials showed us that this type of methodology is a very efficient way to look for large signals. I mean, these were the fastest enrolling trials in the history of ALS. They enrolled 8 to 10 patients per site per month, whereas most ALS trials enroll 1 to 2 patients per site per month. And we got answers quickly and at a fraction of the cost of your typical phase 2A study. So in ALS, your typical phase 2A study would cost $5 to $10 million. My ROAR trials cost about $500,000. So I asked myself last year, if you remember my talk, whether maybe I was looking at this too simply. Like, it seems odd if ALS is not exactly the same disease in everyone, maybe the reason that people recover from it is not the same. So maybe I need to try to personalize my approach. And I decided to do something called the ROAR-DIGAP trial. Same ROAR design features as we talked about, except this time we're going to partner with a company from Australia called Genius. They have this genomics platform called DIGAP, where they can look at the entire genome, not just the ALS-causing genes, but every gene. And they can plug that into a machine learning AI algorithm and ask, how many different genetic abnormalities are associated with specific pathways that can kill motor neurons? And based upon that, in this person, what is the most likely chemical pathway killing their motor neurons? And so we came up with 4 categories: neuroinflammation, oxidative stress, disrupted intracellular transport and autophagy, and mitochondrial dysfunction. And for each pathway, we paired patients with a supplement that we think hits that pathway and that we think is associated with at least one ALS reversal. For neuroinflammation, astaxanthin; for oxidative stress, Protandim; for impaired autophagy, melatonin; for mitochondrial dysfunction, MitoQ. So here's the results, just presented last week in Niels. So the good news is, again, the trial enrolled very quickly. We got answers for a fraction of the cost. Another really interesting finding is that all the treatments that we studied, they all affected a panel of biomarkers looking at these downstream pathways. So for example, every supplement lowered uric acid, every supplement lowered TNF alpha, every supplement lowered CCL2, every supplement raised total antioxidant capacity. So they do biological things, these supplements. It's just that they don't seem to do them specifically. The really bad news is that none of the 4 treatments seem to be associated with any evidence of improvement, not by neurofilament light chain, not by ALS FRSR slope. And we found no new ALS reversals in this study. So I'm going to turn my attention to the thing that I think all outliers, whether they be slow progressors or ALS reversals, have in common. It's the only thing that they all have in common that I found so far in more than 10 years, and that is hope. I think hope is more than just an emotion. I actually think it's a treatment. If you look across every disease where hope has ever been studied, people who have more of it are doing better medically. They have fewer symptoms. They're less likely to be hospitalized. They live longer compared to people with less hope. And so I've spent years now asking myself, where does it come from? And I don't think there's one place. Some people are born with it. Some people get it from their family or their friends or their social circle. But I think many people have to get it from their physician and their healthcare team. And it turns out there's a big literature on this. There's a whole series of hope promoting and hope suppressing physician behaviors that have been identified. Sadly, this is not taught to us in medical school or residency. And I think part of it is because medicine is more than ever now a business. And to engage in these hope boosting and avoid these hope suppressing behaviors, we really have to think carefully about how we're going to do that and still satisfy our business managers, because they take more time And so I have my own approach to boosting hope. I call it stitching strength. It starts with self-care. I've got to understand who I am, what I need for sleep, what I need as far as diet, what things bring me joy. And I got to make sure I'm doing all those things. I got to be careful about the words that I use in clinic. I got to focus on what we can do. I got to try to avoid expiration dates, especially early on in the disease when you really don't know how someone's going to do. When we do have to have a difficult conversation, I think it should be a plan A. We're going to try to do whatever we can to slow, stop, or reverse this, and a plan B. If we don't, we may need to think about things like a feeding tube or a ventilator or a goals of care conversation. And I think those conversations make choices more palatable. And I think it's important that we get to know our patients. Like, the person sitting in front of me is not just another example of ALS. That's a human being. There's a lot of other parts to them. And, while there may only be so much I can do about ALS today, if I understand the other parts of them, there may be ways that I can strengthen them spiritually. And somebody who really opened my eyes to this was a physician at the University of Virginia named Dr. James Plews-Ogins. He used to write this amazing blog. And he taught me to think about ALS in ways I had never come up with and may never have come up with on my own. But one day he said, I just got back from my ALS clinic. It was great. I got a lot of ideas for things that I could do, but I can't help but feel a little bit like a failure. Like, every measurement that they made was worse than it was the time before. And so I'm trying my best to beat this disease and everything's getting worse and I feel like a failure. And he said, what if clinics incorporated something that measured other parts to a person, parts that didn't have to be affected by the motor neurons? And he called it the turbocharged living scale. And he set it up to be just like the ALS FRSR score. It's 12 questions where the answer ranges from 0 to 4, except these are questions about your sense of humor, your kindness, your compassion, your advocacy for others. And it's amazing as we go through that in my clinic, how a person and family just light up and they recognize that there's so much more than their motor neurons. And so I believe this may be the most important thing that I've ever found so far in my career, this approach to getting people to see that they're more than their motor neurons, to boosting hope in them. And I'm so glad that a film company actually made a movie about what I do. And I'll show you a brief preview here. I think, maybe not. All right, well, if you go on YouTube and you Google my name and you put in stitching strength after it, you'll be able to see a preview of the movie. So I do recognize that I'm not going to be able to convince everyone. Many of my colleagues are skeptical that they should put this much time and effort into boosting hope. So I'm going to try to do a clinical trial of hope-boosting interventions to prove to them that these not only boost hope scores, but also boost quality of life scores and slow the disease down. And so right now, we've just got something underway called the Quality Improvement Project. We're testing some different interventions and outcomes, but once we decide which ones we like, we're going to turn that into a clinical trial. And then last but not least, I wanted to tell you about this. So this is just really brand new over the past couple of weeks. Some of you may recognize this handsome fellow. His name is Aaron Lazar. He is an actor. He's a musician, absolutely amazing human being that I've crossed paths with. And so he's got this podcast that he's starting up. And on his podcast, he recently interviewed someone you may have heard of named Mark Cuban, a very wealthy person. And they were talking about this business of studying outliers. And they came up with this idea, well, maybe we should put some companies to work using artificial intelligence to try to mine databases, to try to predict why some people are doing so well. Like, look at all the genomic and proteomic and, medicine, supplements, microbiome, everything that we have in these massive databases to see how it all fits together. And so Aaron made it happen. He's actually got this company called PCCI that right now is working with him, myself, and some other scientists to try to figure out how to specifically employ AI to help us predict who's going to be an outlier. And again, it's not just predicting. Once we understand who it is, we hopefully will be able to make that happen more often. So just to summarize, I probably went on too long, but I've shown you that progression in this disease is really quite variable, both between patients and within a person at different times. I'm trying to understand people who have either very slow progression or recovery of function, ALS reversals, because I believe if I can understand it, I can make it happen more often. We've identified some new targets that we're going after now in trials, the microbiome, IGF-BP7, and HOPE. And I believe artificial intelligence in the next year or two is going to give us a lot more answers. So if you want to be part of this work, every single person listening can join a natural history study. There's several of them out there. These are two of the biggest ones. ALS TDI has something on their website called the ARC. The NIH has something called All ALS. We want every person with ALS to enroll and let us measure everything we can about you, because everyone has something to contribute. And if you are out there and you really believe you're having an ALS reversal, feel free to email me, but I'm going to ask you for records. And I do want to caution you. It seems like every year I run into more individuals and groups who are out there selling things to people, telling them they know how to reverse their ALS if they'll just do so many steps or take so many products or spend so much money, their ALS will be reversed. I promise you, outside of SOD1 and maybe FUS, nobody knows how to reverse any form of ALS right now. And with ALS Untangled, we've created something called the 10 red flags. Please, before you give anyone any money, ask yourself how many of these red flags are associated with this person and what they're asking you to do. Thank you for listening to me. Those of you that are living with ALS, I hope you know you're the reason I'm still in this. You inspire me every day to keep thinking, keep trying new things. I couldn't do it without a lot of collaborators, especially Terry Hyman Patterson and the ALS Hope Foundation, Martha Olson Fernandez Foundation, Augie's Quest, ALS TDI, Hummingbird, Team Drea, Aaron Lazar, and finally my Duke ALS team. They helped me build this foundation of great patient care upon which all my ideas are built. So I'll stop sharing and I hopefully have some few minutes here left for questions.
Thank you so much, Dr. Bedlock. And we did put your link for the video on the chat here, so for everybody to access. So with that, we got a lot of questions, as you can imagine. And as you know that, we have a lot of longitudinal data as well. So we would love to share that with you as you do the analysis. And we have a huge AI and data science team where we did our first FDA, approval for our speech as a biomarker. So we are working with very similar lines. So we'd love to collaborate. And
sounds great. Yeah.
Thank you. And with that, so Anusha and myself will be asking questions today. And our first question would be, what off-label medication would you let your patients try to slow the process, even though it's not FDA approved? For example, do you think use of experimental therapies like, Amylyx? I don't know if you still recommend that, but there was Neuron, and then there was Prolinia, and then there was even clean medication, and then increase the likelihood. Is any of them increase the likelihood of reversal? And for example, what's confusing for people is that Neuron had the IGF factor. Is any of them similar to what you are mentioning as the growth factor that you saw in the reversal of patients?
My gosh, there's a lot of questions in there. But
Yeah.
let me start with the first question that you asked. What alternative and off-label treatments would I let my patients use? I don't like the word let. Like I'm not the parent of my patients. I mean, I consider my interaction with my patients to be a partnership. And so, when people come in, I try to give them all the information that I have about a particular thing that they're asking about. It's ultimately up to them to make the decision. Now, it's a different story if somebody's telling me, I want you to write a prescription for this thing. And I look at it carefully and I say, I can't do it. To me, it looks like it's far more likely to harm you than it is to help you. So it's a partnership. Like I would never tell my patient, you must do this or you can't do that. And I don't expect to be told those things either. It's a partnership. But I mean, when it comes to the alternative and off-label treatments that people can get their hands on, I have a publication out there, which somebody can probably look up and put in the chat. It's from last year, and it's the 8 most promising alternative and off-label treatments that I found in 16 years now of leading ALS Untangled. Next year, that list might be different because new research is being done. But, if a person comes to me and they're not on anything, the first thing I would do is I would say, are you a candidate for a trial? If so, let's find a trial. That's where we get the most exciting products. That's where we get the most information. If there's not a trial, can we get you into an expanded access program? Expanded access programs are the second best thing because they're studying medicines that are in trials, things we know a lot about, things that have a lot of scientific plausibility, things where we know a lot about the purity, things where we can measure stuff in a rigorous way and learn things. Unfortunately, 90 to 95% of people living with ALS in the world will not be able to find a clinical trial or an expanded access program. There's just not nearly enough of these options. And so they'll be left having to self-experiment. And that's part of why ALS Untangled is so important, because we do give people a roadmap. We say, here's what a group of over 100 clinicians and scientists from 11 countries think about some of these products. And that's where we came up with the list of 8. So I would say if you're a new person coming to me for the first time and you have limb onset ALS and you're in the first year of your symptoms, methylcobalamin, high dose intramuscular methylcobalamin, 50 milligrams twice a week. It's pretty clear from multiple well-designed clinical trials done in Japan that if you get that started in the first year of symptoms, it slows progression by more than 50%. We've never had any medicine that works for everybody so powerfully. Unfortunately, most people don't get in to see us within the first year of symptoms, and there isn't any evidence that it works if it started after that. In fact, there's evidence that it probably doesn't work if it started after that. So next, I would say if you have a bulbar form of ALS, speech and swallowing impairments, Nudexta is really promising. And that's an off-label treatment. It's FDA approved for pseudobulbar affect. And there's now 2 really small, but otherwise really well-designed trials suggesting that people who take that have improvements in the clarity of their speech and their swallowing. Unfortunately, we can't yet prescribe it just for those problems. There has to be pseudobulbar affect or insurance won't pay. And then finally, for people who come in, spend more than a year and they have limb onset, not bulbar onset ALS, I really think this product called Basis is interesting. It's sold by a company called Elysium Health. It has 2 ingredients, nicotinamide riboside and pterostilbene. These ingredients have a plausible mechanism by which they could help a person with ALS. But what sets this one apart is the company actually did a clinical trial in people with ALS. And it was small and it was short, but otherwise it was decent. It was randomized, double-blind, placebo-controlled. And what they showed was if you got people up to a high enough dose, over 4 months, they were getting stronger. Like it looked like they were in the beginnings of an ALS reversal, whereas people on placebo were getting worse. Now, do I think that Basis reverses everyone's ALS? Unfortunately, no. As I've said several times throughout the talk, I don't think ALS is the same thing, and I don't think we'll be able to reverse it in the same way in everyone, but I think it's quite promising. So that's what I do with my patients.
All right, thank
Thank
you. So next question is, from your research, it looks like on July 14th, 2020, there was an ALS Untangled review started for bovine colostrum that wasn't completed. Do you have more information on this, and what are your thoughts on the use of bovine colostrum?
Yeah, so it wasn't that a review was started. So with ALS Untangled, people send ideas, and those go onto a part of the website called Future Reviews. And if you go on there, there's about 600 ideas. And I mean, every week there's 4 or 5 new ones that people send me. It seems like, these things just keep getting put out there. And so the first thing that we look at is how many votes does an idea have? So, if an idea gets a lot of votes, it gets assigned to somebody. So I don't remember off the top of my head how many votes bovine colostrum has, but I suspect it's not many. And that's partly because there's not really a great mechanism. There's no clinical trials that suggest that that works. And I'm not aware of any of my 64 ALS reversals where that was associated. So it doesn't mean, we won't eventually do a review and find some possibly interesting things, but certainly nowhere near the top of my own personal list of things I'm excited about.
Got it. Thank you.
And there was a question on, I think your microbiome, the fecal microbiota transplantation was very interesting. When do you expect the study to be completed?
So this is going to be a smaller study than my R.O.A.R studies, and partly because we have to be careful. We have to, really understand that this is safe. It's never been done in this way to people with ALS. There's reasons that we're worried that we could see safety signals. One is before you can reestablish a new microbiome, you have to wipe out the existing microbiome. That's one thing that the previous group did not do. So that means a week of horrendous diarrhea, like the kind of thing you would experience the night before a colonoscopy, but for a straight week. People may lose weight. If they do, that could aggravate their progression. Second, we're asking people to swallow fairly large capsules that are full of stool. So part of the inclusion criteria here is that people have to be able to swallow, and we have to expect they're going to be able to swallow for the duration of the 6-month study. And the reason is if somebody sneaks in whose swallowing is not good, and one of those capsules goes down the wrong pipe, there's now stool in the lungs, which will almost certainly result in death. And that's the end of the study. The FDA will shut it down, and no one will be able to do this ever again. So it's a much more risky study than my typical R.O.A.R study. And that's why we have to be a little bit more careful about who we're enrolling.
This is a follow-up that I think is important to address. So someone said there are a couple of private clinics over here in the UK offering highly tested and vetted stool transplantation from healthy and active individuals. How practical do you think it would be for a person with ALS to follow your study design by taking a broad spectrum antibiotic targeting gram-positive and negative bacteria, then do a colonoscopy prep before doing an FMT protocol with such a clinic? And to what extent is the pill being used in your trial unique and specifically designed to address a shortfall seen in ALS?
Yeah, I don't think it's going to be possible for anyone to even closely follow the protocol that we're using. We have come to believe from years of research at University of Minnesota and years of research at Duke that you cannot drastically change a person's gut microbiome very easily. And so, that's why it took us so long to get to where we are, is we had to develop this protocol with all kinds of input from people across different fields. So just going to a clinic and giving somebody some money and having them, put some stool in you is not going to change your gut microbiome. And, furthermore, I've had some patients ask me like, hey, could I do that? And I look at their progression rate and I say, why? Like your progression is extraordinarily slow. The evidence that we have suggests that you already have a really good gut microbiome. Like this is something that's probably best for people who are progressing very fast. All this could do for a slow progressor is possibly make them worse. That's why I cringe when I hear about patients who go to naturopaths who are doing well already, and they get some sort of stool analysis, which has never been validated, and they get a probiotic, which has nothing to do with anything that we found. And, they're hoping to change their gut microbiome. And I say, I'm hoping you don't. You probably won't, but I'm hoping you don't, because if you're doing extremely well with your progression, you probably already have a good microbiome. Nobody should be trying to mess with that right now.
Great. And on that question, there was not to mess with the microbiome. Do you have any food that people should take to get the best microbiomes to slow the process?
I wish I did. I wish I knew how to, simplify the microbiome and boost P. vulgaris with food or a probiotic. If we knew that, we wouldn't be doing this study. Like I said, this study, if we find something, this is not going to be easily translatable. If we find something, it will probably prompt a lot more companies to do the research on food and probiotics. But I just don't see a day coming when like tens of thousands of people are going to be able to do the protocol that we're testing. It's more of a proof of concept that by being super aggressive, we can change the microbiome, and that does influence progression. But I think ultimately we're going to have to figure out a way to do this in a way that's more feasible for the majority of people living with the disease. So I welcome any kind of research like that, but it doesn't exist right now.
Perfect. Thank you. And L-serine is something that people talk about in ALS. Have you seen any link to reversal?
Yeah. So amongst those 8 most promising products that you'll read about in that article, that's one of them. And so it's got a mechanism that's different than anything else. One of the things that it does is block a toxin that we think might come from blue-green algae, which is called beta-methylaminoalanine. It does other things too, but this is what sets it apart from just about any other supplement. And there is actually evidence from a small clinical trial. When I say small, I mean like 5 patients got different dosages of L-serine, and their progression over 6 months was compared to matched patients from another study. But at the highest dose of L-serine, which was 15,000 milligrams twice a day, it seemed like progression had halted in the 4 or 5 patients that stayed on it for the 6 months. Again, caution is this is not a placebo-controlled randomized trial. It's super small, it's super short, but it's exciting because there's a plausible mechanism and there's evidence from a trial. And yes, there are multiple ALS reversals associated with L-serine. Again, the key word is associated. Just because one thing happened, then another thing happened, doesn't mean the first thing caused the second thing to happen.
Thank you. All right, the next question is there any update on clenbuterol?
Yeah, the update on clenbuterol is it remains one of the 8 most promising alternative and off-label treatments, but what needs to happen next is a more traditional phase 2 trial, like the kind of thing that's done in the Healy platform trial. That's the kind of thing that would get it in front of the eyes of the FDA. Like the FDA does not consider the case series from Italy or the trial that I did, which was small and not placebo-controlled. They won't look at that data. They want, you know, a traditional randomized double-blind placebo-controlled trial. And so if anyone has a spare $15 million laying around, I might be able to convince the folks who decide what drugs go into the Healy platform trial to put clenbuterol in there, but that's what it costs. And there is no company that I've approached who seems the least bit interested, I think largely because they're not sure how they can make money on it. It's an old drug. It's not approved for anything in the United States. So it would be difficult to repurpose it for a different indication and make any money on it. So that's the sad part about clenbuterol. I don't know where it's going to go. I hope maybe some company comes along and thinks of maybe a slightly different formulation, like a long-acting form or something that you can patent, because then there might be some money behind it that gets it into the trial that it needs to have in order to get FDA approved. But it's not easy to get right now. The only way I know of to get it is to import it from another country. And there is a group out there called everyone.org that can help people do that. But again, these kind of decisions, they have to be made in conjunction with a person's doctor. Like it's not right for everybody. It does have side effects. It makes people anxious. It makes their heart race. It can raise their blood pressure. It can give them insomnia. So there's definitely got to be, you know, some conversation between a patient who's thinking of trying that and their physician. There has to be anyway, because everyone.org doesn't just get it for you. You have to have a supervising physician in order to get it.
Thank you. And another question was, how can people not close to Duke participate in your studies?
Well, it depends which study. So the natural history studies that I listed, everybody can participate in those. Like ALS, TDI, no matter where you live in the United States, you can participate in that. All ALS, I believe there's around 60 or 70 centers around the United States. If you go to that link that I had in my slideshow, you can find the centers that are enrolling in that. As far as the clinical trials go, I mean, you know, the next one that's coming up, as I mentioned, is that fecal transplant trial. And we're really focusing on people who live close by. Again, just because we're expecting so many side effects. Certainly, you know, ROAR trials, we do open those to everyone. So I know a lot of people from all over the country participated in ROAR-DIGAP. And we actually had people from all over the world participating in ROAR-Lunasyn and ROAR-Theracurmin. So hopefully when ROAR-HMB comes along, which will be sometime in 2026, that'll be, you know, open to everyone.
Thank you. Next question is, do you have any reversals of bulbar onset ALS with frontotemporal dementia? Then another question on your kind of reversal patient population was, did everyone have familial ALS?
So yes, there are reversals in people with bulbar onset ALS. In fact, one of those is what prompted the Lunison study, a person from Providence, Rhode Island, who made a video and was on the news there. Somebody forwarded those to me, and I talked to his team there, and sure enough, he had bulbar onset ALS. He progressed to where he could not speak intelligibly, could not swallow, had to have a feeding tube, and started on that supplement. And within 6 months, his speech was back, his swallowing was back, all independently verified by his team. And so that prompted, 3 years of my life in contracts and fundraising and approvals and a study of Lunison, which ultimately did not reverse anyone else's ALS. So I don't personally believe that's why he got better. I think that's one of those associations. As far as frontal temporal dementia, I don't know of any of the 64 ALS reversals who had that. Certainly none of the ones that I've personally interviewed, whose records I've poured over, had that. As far as some of the ones that were in literature, like if you were diagnosed in the 1960s, they probably weren't screening for frontal temporal dementia quite as stringently as we are now. So it could have been missed. And then remind me of the second question again.
Did anyone have familial history of ALS?
Yeah. So here we have to make sure that we're talking about the same thing. So familial ALS means you have a family history of ALS. So 4% of our ALS reversals have a family history of ALS. What you may be more interested in is genetic ALS. That's actually a more specific thing, because familial ALS does not necessarily mean there's a gene in the family. Genetic ALS means we found a genetic cause for ALS in the person that we're talking about. And so far of the, I guess, around 25 ALS reversals that we got really detailed genetic information on, we found 2 with known ALS causing genetic mutations, sequestosome 1 and FUS.
Awesome. Thank you.
So to your question on, hope and trying to be thinking about mental health, have you seen ketamine be helpful in reducing anxiety when it related to ALS?
I haven't seen anyone take ketamine in my practice. I mean, certainly it's advertised as possibly being able to help people with like really severe depression or existential distress. And I think there's some studies of it that are happening now for those problems. But no, I haven't seen anyone take those things in my practice.
Thank you.
All right, so the next question is, your research identified a specific single nucleotide polymorphism in the IGF-BP7 gene that is associated with the rare ALS reversals. This variant is a 1-letter change in the DNA of individuals who recovered from ALS, and it was found to be 12 times more common in them than in those whose disease progressed typically. Why is this gene variant linked to ALS reversal so rare, and how does it mutate?
So the short answer is, I don't know for sure that it does cause ALS reversals. I mean, it's certainly much more common to see this in ALS reversals. And I explained, over many slides, why I thought it was plausible that it was related to ALS reversals. So, I mean, the only way that we're going to know if this is truly meaningful is if it gives us a way to reverse ALS. And I'm going to try the nutritional supplement HMB to lower IGF-BP7 levels. I'm trying to get one of my colleagues who knows how to make antisense therapy to make an antisense to IGF-BP7, which would lower it in a much more potent way than a nutritional supplement. So far, no takers, but if any of my colleagues who have a lab and know how to make antisense are out there, let's talk, because I have some funds. And even if we just make it and put it into the SOD1 mouse, I really would love to see what happens.
Great. So what do you think about people with PLS who are slow progressors? Because we have some in the audience who have had PLS for 22 years, and what can we learn from them?
Yeah, no, I mean, I think there's definitely something different about them, and we need to study them. We need to get them into these databases. I mean, I'm curious as to why some of them do develop lower motor neuron signs, sometimes years after they're first seen. And others, even 20 years later, never seem to develop them. Like there's got to be something different about those people that makes their lower motor neurons resistant. It's kind of like, the question of why some people progress so slowly or recover. Something is making their lower motor neurons resistant to deterioration. And we should study that and figure out what it is. You may be interested in knowing, like, amongst the group of 64 ALS reversals, 2 of them so far only ever had upper motor neuron signs. So they're included because it's very difficult to tell, especially for the first several years, if someone has ALS or PLS. But those could be 2 PLS reversals. They're either PLS reversals or upper motor neuron predominant ALS reversals. But I absolutely think it's understudied. And I know some of my colleagues are trying hard to, to get more specific studies of people with PLS. The difficult thing is it's so much more rare even than ALS. There's 100 people with ALS for every one with PLS. So.
Thank you.
This is not a question on reversals, but on triggers. So has there been any evidence of the COVID vaccine invoking something that might have invoked ALS?
The short answer is no specific evidence that the COVID vaccine increases, a person's risk of getting ALS. Theoretically, could any vaccine be part of someone's story? Sure. I mean, most people now believe that sporadic ALS, where we can't find a single gene that's causing the disease, is a combination. And it could be a combination of 3 or 4 susceptibility genes that open the door and 4 or 5 exposures over the course of someone's lifetime. So is it possible that any vaccine, could be the 5th trigger that someone with all that other stuff needed to have to get ALS? Absolutely is. But I've seen no specific evidence that COVID vaccines trigger ALS. And I think it's quite unlikely that they're a major cause. I mean, you think about the number of people in the world that have had a COVID vaccine here in the last few years. I mean, ALS should be everywhere. I mean, I think 80% of Americans have had at least one COVID vaccine. If that's the cause of ALS, why don't 80% of Americans have it? I think because it's more complicated than that.
So there was a question on autoimmune that was, could be the cause of ALS. It's the publication on autoimmune response to C9 protein in ALS.
Mm-hmm.
If with this discovery, would any of your research on reversal change with this information on autoimmune coming to light?
No, I can't think of a different way to go about what I'm doing. I mean, there's a difference between something being associated with ALS and something driving the progression of it. So there's no question that there's inflammation in the brain and spinal cord of people with ALS. And in a lab, maybe some of the things that get exposed can trigger immune reactions, but we really have no idea if that happens in people. There have been several trials of ways to knock the immune system down, whether it's high-dose steroids or IVIG or some of the medicines that are used to treat people with myasthenia gravis. None have ever made any difference as far as slowing the rate of progression. So I don't think it's going to be as simple as ALS is an autoimmune disease like rheumatoid arthritis or, Hashimoto's or myasthenia gravis. It's not going to be that simple. It's possible that for some people it's part of the story, but I don't think it's the story.
All right, so you mentioned the All-ALS study at the NIH that's studying biomarkers. So are you participating in this study, and what are you hoping to learn from the study overall and getting patients enrolled?
Yeah, no, we are one of the sites, and we're hoping to learn a lot of things. So this study enrolls people living with ALS. It enrolls healthy family members. It enrolls people who are at an increased risk for developing ALS because they come from a family where there's genetic ALS, or because they know they have a gene that might someday cause their ALS. And we're hoping to learn a lot of things. I mean, we're hoping to get some ideas about why people get ALS. We're hoping to get some ideas about why some people progress so slowly. Maybe if we get some ALS reversals in that data, why some people recover. We're helping to understand maybe what are some of the first signs of ALS before a person even notices that they have it, before their doctor notices it. That's important because that would be a time to intervene. Like Dr. Benatar found this one biomarker called neurofilament light chain that seems to spike up really high in people with the SOD1 form of genetic ALS. And it spikes up a year before they notice any symptoms or before their doctors notice any signs of ALS. And it's important because it's allowed us to do a clinical trial of the drug, that one home run drug we have, tofersen. We couldn't do that trial without that finding from Dr. Benatar. Like, nobody is going to allow you to start giving a 16-year-old injections of a medicine into their spinal fluid, potentially for the next 30 or 40 years, to see if you can keep them from getting ALS. It's just not going to happen. So you have to be able to come up with an idea of maybe when the disease first starts, and that's when you would start the therapy. And so Dr. Benatar has found this pre-symptomatic phase that's defined by a spike in neurofilament light chain. And now, people who enroll in that trial, when that is seen in their blood, they get randomized to either get tofersen or placebo. And the hope is that we will see that tofersen dramatically delays or maybe even prevents those people from ever getting full-blown ALS.
Thank
Perfect.
you.
Thank you. And also there was another question on ROAR-DIGAP. I think a lot of people, when they first diagnosed, they get into ROAR-DIGAP, and you had not mentioned it. What are your thoughts on that?
Yeah, so again, I'm coming at this from a standpoint of a scientist and also someone who's taken care of a lot of people who took ROAR-DIGAP. So I was skeptical of ROAR-DIGAP when I first heard about it because of its mechanism of action. There are many antioxidants that have been tested in the history of ALS, and really none have worked. Lou Gehrig was on an antioxidant, it didn't work. The first trial of ROAR-DIGAP that was published, a randomized, double-blind, placebo-controlled trial done in Japanese people with ALS, showed no benefit compared to placebo. After that trial was published, the company went back and they said, well, maybe there's a hint of a signal here in people who are really early in their ALS with a lot of function and progressing quickly. So let's do another study of those types of patients. Now, it's a very small subset of people who can meet that criteria. Again, this was done only in Japanese people. And in that trial, again, randomized, double-blind, placebo-controlled, but very small, very short, there was a slight slowing in the rate of progression, about a 27% slowing. Such a small rate of slowing that no person living with ALS could perceive it, no doctor could perceive it. So you had one negative study, you had one positive study, you had a theory about why they were different. A scientist would say, it's time to do a third study, test the theory. That's not what happened. It went in front of the FDA. It was the first thing that came in front of the FDA in a long time, all the way back to riluzole. And there was a pretty feisty hearing, and ultimately the drug was approved. And it would be nice if we had a way to approve drugs in the United States called a conditional approval, which meant, okay, we recognize the unmet need. We're going to get it in the hands of people with the disease now, but we require the company to continue to study it and give us confirmatory evidence that it works. So that never happened. It couldn't happen. There is no such thing as that pathway. The drug's now been approved. I believe 2017 is when it got approved. I've certainly never seen anything in my patients to make me think that it was slowing their progression. There have been some natural history studies where they compare a large number of patients taking it to a large number of patients who aren't taking it, and they try to match those patients as best they can. Some show differences in how they're doing, some don't. The most powerful clinical trial of a form of ROAR-DIGAP called edaravone. This is a slightly different formulation. It's the same parent molecule, but it has different additives. Much larger, longer, more real-world type clinical trial done in Europe by a company called R.O.A.R, I believe. That trial showed zero evidence of benefit. So putting it all together, 2 out of 3 trials of the parent molecule showing no benefit, a mechanism I'm skeptical about, and my own experience, I don't believe it works. And if you come to me and you're not on it, I will explain all this to you, and I will say, I don't recommend that we start it, but if you're just absolutely hell-bent on trying it, my team and I will try to help you get it. I mean, I do think it's safe. It's outrageously expensive, but for people who are just absolutely adamant that they want to try it, it's FDA approved. I'll try to get it for you. If you come to me and you're on it and you seem to be doing better than average, I won't stop it. usually what happens if someone comes to me and they're on it is they're not doing well at all. And I explain like all the things I just told you about. And I say, you're doing worse than the average person. Why would we want to keep doing all the same stuff? Let's try something completely different.
Thank you. And this is my last question, and this is probably in everybody's mind. Dr. Bedlock, everyone listening to you want to be in your trial or want to do something you are doing to do something about the, reversal or even slowing down the progression and give the data back to you. Everybody wants to participate. And as you know, we do a lot of longitudinal study as well. And people ask this all the time. How does one participate and how do we scale what you're doing to do it faster, more at scale?
Yeah.
Anything we can do to help partner with you and be in this together with you?
Yeah, no, I think it's a great question. What I say is I put the protocols out there so other people can follow them. Now, in the past, that's usually individuals, a lot of times in other countries that email me and they say, hey, I took your protocol to my doctor and we're going to try this together. And I say, that's great. I hope it works. If you don't mind, just email me once in a while and let me know what happened. But I mean, if you want to do it in a more rigorous way, I mean, with all the infrastructure that you've built into, I mean, once we settle on, the exact product and dosing strategy that we're going to use, I see no reason why you couldn't say, hey, we're doing the EverythingALS natural history study. It's going to be similar, not exactly the same as Bedlack's, because we're going to do biomarkers that you may not be able to do. Like we're going to do, neurofilament in the blood and spinal fluid and IGF-BP7 in the blood and spinal fluid. But I mean, you could do all of the other markers of progression that are easier. And then, if I say, well, there's a hint of a signal here, I wish I would have done a bigger study. I could say, hey, Indu, I did 50 patients and you did 500. What did you find?
Got it. We're on it. We're going to sign up for that. So with that, Dr. Bedlock, it was such a pleasure to have you. If you can share a few words on what your evening looked like for the people here. I think we had over 300 to 350 people who attended. And we really cherish your time here, and you spending this hour and a half with us means, that hope, right? That hope you mentioned. So you're imbibing a lot of hope here. So thank you.
Well, thank you, Indu. I have to say, I mean, all of us face challenges. I didn't train, most of my life to watch my patients become more disabled and have shortened lifespans. But I think if you carry a light, you need not fear the darkness. And that's one of the things I love about what you do. It's one of the things I love when I hear McFinn speak. There's just a light that EverythingALS projects. And I think some of it is just understanding that we're more than our motor neurons. I mean, yeah, science is evolving. I really do believe in the next few years, we're going to have more ways to stop or reverse the things that are killing our motor neurons. But in the meantime, we can strengthen ourselves spiritually in so many ways. We can still have great lives.
Thank you, Dr. Richard Bedlock. And that's something that we did not have when we were going through ALS with my husband, who passed away in 2019. So I'm so glad to say that this creates light, because that is the only motive we are doing what we're doing to really change that. And so thank you very much for your evening. And with that, we would love to have you, but I know that, it's an hour and a half already, and have a great evening. And I think a lot of people want to say hello to you at MND conference if you're going to be there in San Diego.
I'm working on it. It's a challenging time now from a funding standpoint. Travel's been really drastically cut back, but I hope to be there. We'll see.
Thank you, Dr. Bedlock.
Thank you, Dr.
everyone.
Bedlock.
Thank
Thank you
Bye.
so much.
Yep.
And to all of you who have attended
you.
tonight, you just showed that we can do something together. And together, we can make a difference in each one of our lives.
Thank you.
Pick out somebody tonight you want to say goodnight to. This has been a really friendly group, and just say it. Eddie,
Good
nice
night,
to see you
Eddie.
tonight.
Good night,
Good
Lisa.
night.
Good
Good
night,
night,
John.
Joe.
Good night,
Good night,
David.
Yvonne
Good night,
and Sean.
Nick.
Good
And
night,
good night,
Tim.
Dr. Bedlack.
Good night, Stan.
Good night,
Bonnie.
Thank
Bonnie.
you.
Good
Good night, Dr. Bedlack.
Mila.
Good night,
John.
everyone.
Night,
Thank
Diane.
you so
much.
Brian.
Good luck.
Bye,
Good night,
Nusha.
Paul.
See you
Thank you,
next
Dr.
week.
Bedlock.
Bye-bye,
Thank
everyone.
you, everyone.
Thanks again,
Thank you
Dr.
so
Bedlack.
much.
Good night, my friends.
We're a united family. Don't forget it. And anytime you need to talk to somebody, you can talk to a Pathfinder. Love you,
Hope
folks.
is important. Hope, 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 you know, come to us.
Yes, amen. Hope.
Yes.
Hope is medicine and it's real and it comes
David.
right out of
Thank you.
here.
Remember,
So
Thank
don't
you.
give up.